Hello everyone, and welcome to our virtual resident education lecture series brought to you by the American Academy of Neurology. Today we're diving into a fascinating and absolutely critical field of neurology, sleep medicine. I'm thrilled you're joining me for this deep dive into the world of sleep. So why is sleep so important? We spend about a third of our lives doing it, yet for many it remains a mystery. As future neurologists, understanding sleep isn't just an elective topic. It's fundamental to diagnosing and treating a vast array of neurological conditions. Sleep disturbances can be a primary complaint, or they can be the first clue to an underlying disorder like Parkinson's disease, dementia, or even epilepsy. A good night's sleep is not a luxury. It's a biological necessity for brain health, memory consolidation, immune function, and emotional regulation. When sleep is disrupted, the consequences can be profound, affecting everything from a patient's mood and cognitive performance to their overall physical health. That's why a solid grounding in sleep medicine will make you a more effective and holistic physician. Let's start with the basics. The architecture of sleep. Sleep isn't a monolithic state of unconsciousness. It's a highly structured journey through different stages, cycling throughout the night. We broadly categorize sleep into two main types: non-rapid eye movement, or NREM sleep, and rapid eye movement, or REM sleep. NREM sleep is further divided into three stages. Stage N1 is that light, drowsy state right as you're drifting off. You might experience a muscle twitch, what's called a hypnic jerk. Stage N2 is a deeper stage of sleep where your brain waves slow down, punctuated by characteristic patterns called sleep spindles and K-complexes. This stage accounts for the majority of our total sleep time. Finally, stage N3 is the deepest, most restorative sleep, often called slow-wave sleep. This is when your body does most of its repair work, and it's very difficult to wake someone from this stage. After cycling through the NREM stages, we typically enter REM sleep. This is the stage most associated with vivid dreaming. Your brain becomes highly active, almost as if you were awake, but your body's voluntary muscles are temporarily paralyzed, a protective mechanism called REM atonia, which prevents you from acting out your dreams. Your eyes dart back and forth rapidly behind your closed eyelids, which is how REM sleep gets its name. These NREM and REM cycles repeat approximately every 90 minutes throughout the night, with the duration of REM stages getting longer as morning approaches. Understanding this normal sleep architecture is the first step in recognizing when things go wrong. So how do we study this intricate process? The gold standard for evaluating sleep is an overnight sleep study, known as a polysomnogram, or PSG. A PSG is a comprehensive test that records various physiological parameters while a patient sleeps. We use an electroencephalogram, or EEG, to measure brainwave activity, which tells us the sleep stage. An electrooculogram, or EOG, records eye movements, crucial for identifying REM sleep. An electromyogram, or EMG, typically placed on the chin, measures muscle tone to detect that REM atonia we talked about. But that's not all. We also monitor heart rate and rhythm with an EKG, breathing effort with belts around the chest and abdomen, airflow through the nose and mouth, and blood oxygen levels with a pulse oximeter. A PSG gives us a complete picture of what's happening in the brain and body during sleep, allowing us to diagnose a wide range of sleep disorders. Now let's discuss some of the most common sleep disorders you'll encounter. First up is obstructive sleep apnea, or OSA. This is an incredibly prevalent condition where a person's airway repeatedly becomes blocked during sleep, causing them to stop breathing for short periods. These pauses, called apneas, lead to drops in blood oxygen levels and brief arousals from sleep, even if the person isn't aware of them. Patients often present with loud snoring, daytime sleepiness, and morning headaches. On a PSG, we'd see the cessation of airflow despite continued breathing effort from the chest and abdomen, followed by an arousal and a drop in oxygen saturation. Untreated OSA is a major risk factor for hypertension, heart disease, stroke, and diabetes, so early diagnosis and treatment, often with a CPAP machine, are vital. Next, let's talk about central sleep apnea, or CSA. Unlike OSA, where the airway is physically blocked, in CSA the problem lies with the brain. The brain fails to send the proper signals to the muscles that control breathing. So, on a PSG, you would see a cessation of both airflow and breathing effort. CSA is often associated with other medical conditions like heart failure or stroke, or can be induced by certain medications like opioids. The treatment for CSA is different from OSA and might involve more advanced forms of positive airway pressure therapy that can provide a backup respiratory rate. It's a classic example of how a sleep problem can be a direct manifestation of a central nervous system issue. Another major category of sleep disorders is the parasomnias. These are undesirable physical events or experiences that occur during sleep. They can happen during NREM sleep or REM sleep. NREM parasomnias include sleepwalking, sleep talking, and night terrors. These typically occur during the deep N3 stage of sleep, more often in children, and the person usually has no memory of the event. On the other hand, REM sleep parasomnias are quite different. The most notable one is REM sleep behavior disorder, or RBD. In RBD, that protective muscle paralysis during REM sleep is lost. As a result, patients physically act out their dreams, which can be vivid and often violent. This can lead to injury to themselves or their bed partners. RBD is a significant condition because it is very strongly associated with neurodegenerative diseases, particularly synucleinopathies like Parkinson's disease, Lewy body dementia, and multiple system atrophy. In many cases, RBD can precede the motor symptoms of these diseases by years or even decades, making it an incredibly important early warning sign. Let's also touch upon insomnia, which is perhaps the most well-known sleep disorder. Insomnia is characterized by difficulty falling asleep, staying asleep, or waking up too early, despite having adequate opportunity for sleep. It must also cause daytime impairment. It's crucial to differentiate between acute insomnia, which might be triggered by stress, and chronic insomnia, which lasts for at least 3 months. While sleep hygiene education is a good start, the first-line treatment for chronic insomnia is actually cognitive behavioral therapy for insomnia, or CBTI. This therapy helps patients reframe their thoughts and behaviors around sleep, addressing the root causes of their insomnia rather than just masking the symptoms with medication. As neurologists, understanding CBTI principles is extremely valuable. Finally, let's discuss the disorders of hypersomnolence, characterized by excessive daytime sleepiness. The classic example is narcolepsy. Narcolepsy is a neurological disorder caused by the loss of specific neurons in the hypothalamus that produce a neuropeptide called hypocretin, or orexin, which is crucial for promoting wakefulness. The hallmark symptom is overwhelming daytime sleepiness and sleep attacks. Other classic symptoms, which make up the narcolepsy tetrad, include cataplexy, a sudden loss of muscle tone triggered by strong emotion like laughter, as well as sleep paralysis and vivid dream-like hallucinations as one is falling asleep or waking up. The diagnosis is confirmed with a PSG followed by a multiple sleep latency test, or MSLT, which measures how quickly a person falls asleep during a series of daytime nap opportunities. As we wrap up, I want you to remember that sleep medicine is an integral part of neurology. The patient who comes to you for headaches might have them because of undiagnosed sleep apnea. The patient with new cognitive complaints could be suffering from severe sleep fragmentation. And the patient who reports acting out their dreams might be showing the very first signs of a serious neurodegenerative disease. By asking about sleep, by being curious about this third of your patients' lives, you can uncover crucial diagnostic clues and dramatically improve their quality of life. The brain does not rest when we sleep. It performs a host of essential functions. And as guardians of the brain, it is our job to protect and understand all of its complex activities both day and night. Thank you so much for joining this lecture on sleep medicine. I hope this overview has sparked your interest in this dynamic and rewarding field. Don't forget to explore the other lectures in our series. Please like this video, subscribe to the channel for more educational content, and feel free to leave any questions in the comments below. We'll see you in the next lecture.